Today is May 24th, 2023. My name is Karen Neurohr. I'm a professor at the Oklahoma State University Library. I work for the Oklahoma Oral History Research Program. And today I am with Professor Neil Hann in the Hudson College of Public Health at the University of Oklahoma Health Science Center in Oklahoma City. Professor Hann is chair of the Department of Health Promotion Sciences, and he directs the Bachelor of Public Health program, the Center for Public Health Practice and Experiential Learning. And I think I read that you also serve as the HCPH liaison to the Oklahoma State Department of Health.
Mm-hmm.
So we're here today to talk about Professor Hann's experience during the COVID-19 pandemic in Oklahoma. Upon the agreement of Professor Hann, this interview will be archived at the OSU Library for future generations to see. So thank you for agreeing to participate in the interview today. So tell me a little bit about yourself.
Well, hello. Again, my name is Neil Hann. I grew up in the St. Louis area and came to Oklahoma in 1977 to go to school in Tulsa at Oral Roberts University. And then moved to the Oklahoma City area in August of '81, where I attended graduate school at the OU College of Public Health. And shortly after graduating, I started working at the State Health Department as a health educator and spent my entire public health practice career there for 34 years. I retired from the State Health Department as an assistant deputy commissioner for Community and Family Health Services in March of 2017, and did some consulting work for a little while, and actually came back to the State Health Department just in time to help with the pandemic response. Did that response for several months, and then came to the OU Hudson College of Public Health in August of 2020 as a full-time professor and director of the Experiential Learning Program, and eventually became chair of the Department of Health Promotion Sciences about a year later.
Had you been teaching here all along while you were working for the State Department of Health?
Yes, throughout my entire career, 34-year career, I taught courses, full semester courses as an adjunct professor on and off. And so I maintained a relationship with the OU College of Public Health during my practice career. In August of 2020, the dean at the time, Dean Raskob, reached out to me and was interested in having me take over the practicum program for MPH students because of my practice experience at the State Health Department. And it was an offer I couldn't refuse. So I came into the academic world.
Okay, thank you. I'm going to just take a little precaution here. Okay, so take me back to when you first started hearing about the coronavirus. What are your memories of first realizing that this pandemic was going to significantly affect day-to-day life?
I actually was asked to come back to the State Health Department in January of 2020, not to respond to the pandemic, because it really had just been getting going in Europe at that time, of course, first in China. The reason I was asked to come back as a consultant was to help re-engage communities. Part of my practice career before I became an assistant deputy commissioner was director of the Community Development Service. And I was very passionate about working with community partnerships on health improvement initiatives. And the commissioner at the time, as well as the deputy commissioner at the time for community health services, wanted to kind of re-engage and reinvigorate that community partnership process that we had developed under my tenure at the State Health Department. So that was the reason I came back in January. And then by about the 1st of March, toward the end of February, middle of February, I guess, really, we started learning more and more about the coronavirus. And we, of course, were concerned. We thought it could potentially be an issue for the United States and Oklahoma in particular. And sure enough, it finally hit. I think the big news was when we had to cancel the basketball game, the Thunder game, in Oklahoma City. And so I got pulled immediately into the pandemic response and helped the Deputy Commissioner, Keith Reed, who is now Commissioner of Health, helped him with the response. So it was, that was intense.
How long were you in that position of the pandemic response?
Probably starting right around the 15th of March through August 1st. It seemed much longer than those few months.
What were the early obstacles that you all were encountering at that time?
Early obstacles, probably the same ones that were common around the country. We didn't have sufficient PPE. The PPE that we had was in warehouses that we had stored for years. And of course, the PPE was out of date. So then we were scrambling to try to get sufficient PPE for hospitals as well as our own public health staff. We couldn't find any. Everybody around the world was trying to find PPE. There was a shortage. So that was one obstacle. Another obstacle was just ramping up the testing, having enough supplies. And very, very quickly, we ran into the issue of not having enough capacity to actually run the samples, to test the samples. And so that was a huge issue almost from the very beginning of the response for the pandemic. We simply did not have sufficient public health lab capacity to run the samples.
Then was it a little later when you got into any supply chain issues like cleaning agents and things like that?
Yes, that came, I would say, a little bit later. The biggest issue right off the bat was the PPE, the testing supplies. The cleaning supplies were not as big of an issue. At least I don't recall that it was at the very beginning. As the pandemic wore on, of course, it became an issue, not just for public health, but for everybody. Nobody could get cleaning supplies, even at Walmart or Target. And so that did become an issue probably closer to mid-April, when it really became an issue in terms of having sufficient cleaning supplies. One way we dealt with that, particularly when looking at and trying to help nursing homes, and we can talk a little bit more about the whole nursing home response, but we utilize the National Guard and they have a special unit that focuses just on hazardous cleaning. And we use that unit to go into nursing home facilities once a case was identified, and they would help that nursing home disinfect and clean after the patients were isolated. So that was a big help when there was a shortage of cleaning supplies otherwise.
So you said National Guard?
National Guard.
Oh, National Guard.
Yeah.
Sorry.
Yeah.
Yes.
The Oklahoma National Guard.
Okay. So they were helping with that.
Yes.
Okay. So what were your days like? Long days? Were you putting in extra hours, or were they 8-hour days?
They were very long days. Easily 12 hours a day. Weekend calls. Just depending on the situation, I would have. Essentially, my role was to assist the deputy commissioner manage the response at the county level. And so I was really working very closely with all the regional administrative directors at the county health departments. And so if there was an outbreak at a nursing home, we couldn't wait. We'd have to respond on Saturday. We would do whatever it took to go into that nursing home, help that facility isolate the patient, do testing of staff. And so it was never, you really were never off. It seemed like you were always on because there was always something going on. And in terms of my role, I took really worked very closely with the regional directors because Deputy Commissioner Reed was usually at the governor's office at the multi-agency coordinating committee. And so he was very busy really working with the leadership at the state on the response. And so I kind of came into that role or fell into the role of working very closely with all the county health departments and the regional directors.
How many regional directors?
We had at the time 9 regional directors. They've increased that number now to 10. But they're all responsible for 4 to 5, 7 county health departments within their region. So we have a total of 68 county health departments in the state. I think 82 sites total. We have some counties that have 2 or 3 county health department sites.
Mm-hmm. The larger urban areas.
Yeah, yeah. Now the urban areas are separate from the state health department system, and so Tulsa Health Department is not part of the state health department system. They have their own board of health, as does the Oklahoma City County Health Department. So they are not directly under the purview of the Commissioner of Health. During the response, of course, we worked hand in hand with both Tulsa Health Department and Oklahoma City County Health Department in the response because they take up, 2/3 of the state basically in terms of the population.
Mm-hmm. So how was the communication occurring throughout this? Were you having to use your phone? Were you taking lots of phone calls? Was it mostly email? What was happening?
It was a combination of both. Certainly, we were on the phone quite a bit. We sent out multiple emails to mainly I would send out emails about a particular issue or response that was needed to all the regional directors, and that would go out. That was the quickest way for us to communicate. If there was an urgent, very specific issue that was only occurring within one county, such as a case that was discovered at a long-term care facility, or a case that was discovered in a jail, or a meat processing plant, then I would call the regional director directly just to try to get a quicker response. But for the most part, it was email communication, but that was even problematic. There were several times when I would be sending out information about the pandemic, new information that we had learned about the coronavirus, and I would be literally typing. Somebody would rush into my office and say, the information has changed. I would have to rewrite the email before I sent it out. Or if I pushed send too quick, within a few minutes, because things were changing so rapidly, I would have to send up a follow-up email and say, this is a new directive that we just received a few minutes ago. Mm-hmm. So it was fast and furious. The science of the virus was changing minute by minute information that was being filtered down from the feds to the states was changing minute by minute. And so it was like that from March 15th until I left to come to the Hudson College of Public Health on August 1st. Rapid fire, things changing constantly.
What were, from your perspective, you were dealing with the regional health directors, and then they were dealing with the people under them, and so forth. So the regional health directors, what were some effective ways that they were helping their supervisors and staff? And was there discussion going on about, how can we manage this stress and, and this kind of thing?
That's a great question. In terms of managing the stress, I don't know that we managed it very well. It was extremely stressful. Part of those 12-hour days and weekends were the regional directors calling me just because they needed somebody to talk to. And so I felt at times I was a counselor, I was a sounding board, I was somebody that they could yell at because they had nobody else to yell at. And I would just sit there quietly and listen while they were talking. They were going through a lot during the response, not just trying to manage their staff, but they had their own family members who were getting sick. They had their own staff members whose their moms were dying because of the coronavirus. And yet they had to persevere and work through the pandemic during their own time of family tragedy, with people getting sick, people dying. And it was just, it was a very difficult time, and there wasn't really a way to manage the stress. You just had to power through it. But I felt that the best thing I could do was simply be the person who could listen to them, try to support them in any way possible that I could, be that sounding board, and be the person they could yell at if they needed somebody to yell at.
So how were you able to help yourself through that? Was there anything that you found helped you with dealing with that? It was very, very stressful. I don't know that I dealt with it particularly well, other than I tried to take care of myself. I would go out and try to exercise, jog. Of course, nobody hardly was doing that during the pandemic, but it felt good to get out and jog without a mask on. And that was probably the way I managed my stress the best, was simply try to get some exercise. But it was, I don't think that none of us really had great coping mechanisms. We were, of course, the colleagues, I was always at the state health department, and we were very close. The ones working there in the state health department were very close. Most staff were working remotely. We switched to remote work pretty quickly, but the key leadership was still there in the office. And so, we just relied on each other. We were sounding boards for each other, and that's how we got through it. Okay, talk to me a little bit about some of the partnerships that the health department strengthened, or new ones that were formed to help deal with all of this.
Well, I think the partnerships were key to helping us get through the pandemic. The work that I was involved with before I retired was all about developing community partnerships. I was over, as I mentioned, Director of Community Development before I became an Assistant Deputy Commissioner. And we had an initiative called Turning Point, which was originally funded by the Robert Wood Johnson and Kellogg Foundations way back in 1997 was when it was funded. We still have the Oklahoma Turning Point Council to this day, so more than 25 years later, it's in existence. And many of those Turning Point partnerships that we developed are still in place and still doing great work. We started out with 3 community partnerships and built it up by the time I retired to about 70 community partnerships all across the state. So that laid the foundation. Those community partnerships, working with community groups, laid the foundation for being able to respond to the pandemic when it occurred in March of 2020. Those partnerships were with schools, they were with hospital systems, they were with local businesses, they were with the PTA, they were with all of those key players within the community. And so we were going into the pandemic knowing who our community partners were, knowing who we needed to call to get some help. And I believe that was really key to making things run as smooth as they could during a time of uncertainty and things changing minute by minute. So those partnerships were critical. And I think as we moved along, we developed additional partnerships with first responders, with police, but we already had some of those developed. Just to give you an example, one of the original Turning Point partnerships in Guyman, Oklahoma, was the fire chief was the partnership chair of that partnership, and his name was Ed Kirtley. And I always use him as an example of an effective community partner who really made a difference in his community. But those stories are across the state, and so those partnerships were critical to the response for the pandemic.
Were there any areas of the state in which those partnerships did not exist?
I think probably there are pockets in the state where they were not as strong. But I think, for the most part, even if we didn't have a formal Turning Point partnership or hadn't done as much community engagement in one part of the state, the regional directors themselves are very, very good at going out, knowing their community, knowing who to work with, and engaging those key partners that ultimately provided a tremendous amount of assistance during the pandemic. So I think overall, between the work that we did through Community Development Service and the Turning Point Initiative, and then just the ongoing relationships that I know each of the regional directors really work on, those kind of partnerships and relationships made a big difference. I was once told when I was doing community development and kind of learning what that looked like from some of my mentors after we got the Kellogg and Robert Wood Johnson funding, they said, you shouldn't be handing your business card to the fire chief when an emergency occurs. You have to have those partnerships built in advance, and that's really the key.
Were some of the partners tribal nations?
The tribal nations were absolutely amazing. They were, again, I think one of the most important partners that we had during the pandemic. They opened up their facilities for testing to everybody, even if you were not a tribal member. They, once the vaccine started coming out, and I was not there during the vaccine rollout, but I kept in touch with my colleagues. They opened up their facilities to start providing vaccinations. Prior to the pandemic, we worked closely with the tribal nations on things like flu shots and other immunizations. So they were absolutely critical to the response. They are fantastic partners, and they have outstanding facilities. They have built really good public health and healthcare system facilities for their tribal members, and they were more than willing to assist the state health department and county health departments during the pandemic response.
Okay, you mentioned nursing homes or assisted living facilities. Talk about that a little.
So that was really one of our big challenging concerns was when we began to realize how vulnerable the individuals who were in long-term care facilities or assisted living facilities. We, as other parts of the nation, started having very high rates of infection and death of those residents in our long-term care facilities. And we were trying to figure out how to better respond and prevent these exposures from happening within the long-term care facilities. So eventually, after, trying to respond the best that we could, we developed something called rapid response teams that consisted of usually an epidemiologist, regional epidemiologist, a communicable disease nurse, a long-term care nurse and the long-term care nurses are the ones who go out and inspect the long-term care facilities, and then a couple other county health department staff. Once we got notice from a long-term care facility that they think they had a suspected case, this rapid response team would go in, they would don their PPE, and do testing of the individual, isolate the individual from the rest of the people on that nursing home floor or ward or hallway. And then they would work with the long-term care facility staff to try to determine the source of the infection, how this person got infected, and then work with them to disinfect and do all the cleaning that was necessary. And this is where the Oklahoma National Guard came into play later on to help us do that cleaning. But that once we set up the rapid response teams, I think that helped, and we probably saved some lives because of that, by being able to isolate those individuals. But we were isolating not only people in long-term care facilities, but also we worked with other locations that had individuals who lived together in close proximity, such as jails and other facilities that had a lot of people living together.
Mm-hmm. So about what month was the rapid response team work and all of that? About when did that kick in?
That kicked in really probably the first part of April.
Pretty quickly.
Pretty quickly.
Yeah.
I mean, we were very concerned. We started having nursing home issues and deaths and infections pretty early on in the pandemic. And so I would say by the first part or by mid-April, we had set up the rapid response teams, as I recall, to try to stem that response. And of course, what we finally figured out was that the main source of the infections were really the staff coming into work, the nursing homes. Mm-hmm. Many of the nurses' aides worked 2 or 3 different nursing homes. And so they would go from one nursing home or long-term care facility to another, and suddenly we'd have 2 or 3 where we'd have an outbreak and we had to isolate.
So that sounds like there had to be a lot of data management going on too.
Yes. Was
there a system in place for that?
We certainly worked very closely with the long-term care service at the state health department. They maintained all the data in terms of staffing and other data that is required to be transferred from a long-term care facility to the state health department. So yes, we used the long-term care service to help us with all the data management. But in terms of just the response, I mean, that was a collaboration between long-term care service, their long-term care nurses, and then the county team that would go into a facility.
All right, talk to me a little bit about the hospitals and the involvement of the regional directors or the county health departments with the local hospitals and how what was happening there.
I would say the hospitals, we probably did not work as closely at the local level with the hospitals. Most of the hospital coordination in terms of PPE distribution, ventilators, was probably more handled at the state level rather than the local level. Of course, we continued to maintain those relationships. The county regional directors maintained relationships with hospital staff and did whatever we could locally to get them the PPE and testing supplies that they needed. But a lot of that coordination was being handled by the MAC, the multi-agency coordinating group, at the governor's level, the executive level. And so, of course, there was a lot of discussion about ventilators, PPE, about expanding the number of beds, and if we needed to expand beds, and then trying to work with more rural hospitals who didn't have the capacity to handle very sick patients, and trying to figure out how to get those patients transported to a different facility. So that was probably one of the key things that the regional directors would do in the more rural areas. They would try to help the hospital staff, the hospital administrator, identify where they could transfer a patient if they had a very sick patient that they really couldn't handle because they lacked the equipment such as the ventilators, and they needed to get them to a different ICU unit somewhere. There's just limited capacity locally for ICU rooms and the equipment that was necessary to treat those very sick patients.
So you mentioned that Keith was deputy commissioner, and he was up at the state level.
Yes.
Dealing at that level with everything.
Yeah, he spent a lot of time at the executive level with the governor's office.
Were you also participating in any state level meetings or anything?
I was always at the state health department building,
okay.
Trying to manage things there while he was at the governor's office.
Were you holding meetings for the regional health directors?
Yes.
Virtual meetings?
Virtual meetings via Teams, but we would have regular meetings on a regular basis. I think, as I recall, I'm trying to remember now, I think it was almost every morning we tried to meet. If not every morning, it was every other morning. And then we, of course, if there was an urgent issue, we would call a special meeting virtually to discuss whatever the issue was. But yeah, we were in very, very much regular communication with the regional directors.
Do any of those particular meetings stand out in your memory?
Yeah, I think the ones regarding the long-term care facilities were the most challenging ones in terms of what to do with the response. And then we had other meetings about just the stress that their own staff were experiencing. The regional directors were desperate to get additional assistance because their staff needed a break. They couldn't keep going. And so there were a lot of discussions about how we could redeploy people from the state health department to just help with things like contact tracing, where they didn't necessarily have to be on site locally, that could be done remotely. But their staff needed a break. And I just recall a couple times where, I was speaking one-on-one or with my assistant deputy commissioner who was working with me. Her name is Tina Johnson. I recall a couple meetings where our regional directors just were bursting into tears because they just were so stressed out. They were desperate for additional help. And of course, they were concerned about their own staff. So I think those are the meetings that I remember the most. Just the long-term care facilities and how to make an impact. But then, the almost desperation with the regional directors about getting additional help because their people were working, more than 12 hours a day, every weekend. Nobody was getting a break. So you would have these long days. I mean, we would start at 7, go at least until 7 in the evening. When I got home, I would have calls from regional directors, or I would be on the phone with, as a matter of fact, the OSU and laboratory about a new set of samples that were coming, and coordinating those efforts, coordinating the transportation. This was happening late in the evenings. But then I would have to call the regional directors and say, I'm sorry, but it looks like we have a new outbreak in your area. We need to do testing on Saturday and Sunday. I remember, I think it was during July 4th weekend, I had to ask all of the regional directors, we got to get some more testing done, and you're going to have to work this weekend. And they just about melted down because they hadn't had a break. But they picked themselves up. They did it. But that's just the way it was for several weeks.
What can you tell me about governmental messaging and leadership, either federally, state, or local, during that time period?
It was challenging. We were getting different messages, and it started at the federal level. It was inconsistent messaging. It was messaging that was inaccurate at times, and I don't know that I can necessarily blame anybody because we were still learning about the coronavirus. It was changing rapidly. But I think the worst part was the inconsistent messaging. So where at the federal level, people were being told that there's plenty of testing supplies. We encourage you to get tested, and so that message was coming down from the federal level down to the state level and then out to the local communities. And the reality is we didn't have the supplies to test. And so then people were getting frustrated. Or when we finally had sufficient supplies to test, we quickly ran out of lab capacity. And so those were the challenges, I think, that were making not just our staff frustrated, but then the community members were frustrated because they were hearing different things. And then when we told them, we're sorry, we don't have the supplies right now, or we can't do testing this weekend, then they would get frustrated. Or if we ran out of lab capacity and we had to halt for a little bit, they would get frustrated. And so that all of that was taking place through the end of April, beginning of May, and then we finally slowly started getting things turned around where we did have additional supplies coming in. The lab capacity took a while to get caught up with. And the one facility that really saved us was the OSU lab. They converted their animal testing to human testing. And if we hadn't been able to work with them to get that testing facility up and running, I don't know what we would have done, honestly. We tried contracting with some vendors around the country. There was one vendor. I don't know if I'm supposed to name the vendor.
You don't have to. I mean,
it was in Lubbock, Texas, and they made a lot of promises in terms of testing. They said that they could take saliva testing, which was not a proven test yet, a reliable test. But it turns out that once we started sending samples to Lubbock, Texas, to this particular vendor, we found out that they weren't getting the testing done. And in fact, they had a backlog of samples that were 2 or 3 weeks old. Of course, that was no good at that point. So that's just one example of the issues that we ran into. So then we tried to find another vendor. The other vendor was in Tennessee, I believe. And so we were FedExing samples to this other lab in Tennessee. And they helped, actually. They were a good facility, but it was extremely expensive. And so those were kind of the stopgap measures that we tried to do while we were trying to get our own state lab capacity up and running. Our own public health lab at the state health department only had the capacity to run about 400 samples a day, which was not nearly enough. Eventually, OSU got upped their capacity to about 1,500 to 2,000 samples a day. But even they got backlogged. And so those were those evening calls when I would work with the lab director at the time, or the one in charge of the COVID testing. Her name was Dr. Amy Brown. And I would work with her. I would let her know how many samples were coming from each region of the state, and just to give her a heads up so that she could then get her staff prepared to receive all these samples, because they would be working evenings and weekends too. Everybody was working all the time. And so I was coordinating with her to get the samples up to Stillwater. We were using a courier service. The courier service eventually failed. We lost samples because they couldn't get the samples transported to Stillwater in a timely fashion. So then we were able to convince the governor to help us deploy the National Guard to help us with just transporting samples. So and it was all complicated and technical. You know, I never thought I'd be talking to lieutenants in the National Guard about transporting samples to get tested at OSU, but those were the kind of coordinating issues that we had to deal with.
So tell me about the COVID relief funding that started coming down, and what comes to your mind about that?
The COVID relief funding was helpful. Certainly, without that funding, we wouldn't have been able to, do the things that we needed to do, like eventually buy PPE when it became available. That was very, very important. Testing supplies. We also were able to use some of the funding to eventually buy some mobile units that went across the state. They were not really in place. I was actually responsible for doing the orders. We ordered 5 large trailers that were pulled by big diesel trucks, not 5, 9, total, 1 for each region, as well as 9 smaller vans. And the purpose of those units were to be able to get out and do things like testing and immunizations at the local level. I got those ordered, and they were not in place by the time I left the state health department to take my position at the Hudson College Public Health. But they are in place now. They were useful, particularly with the vaccine rollout. They were very, very helpful to get the COVID-19 vaccines out to the local level. So the funding from the feds was important, and it was also important for our staff because, of course, our staff were working many, many hours, and we were able to use some of that federal funding to help pay for overtime for staff who were working ridiculous hours. I mean, that's the least we could do to support them as they were working so many hours. And we were able to get approval to use those funds to help pay for some overtime for those staff.
There were public campaigns going on that were describing the essential workers, the frontline workers, as heroic. What comes to your mind about that?
There's no question they were heroic. Of course, I'm a little biased. I would probably say, in addition to the frontline workers like the emergency response, the EMTs, the firemen, our public health nurses are absolute heroes. They worked these ridiculous hours. They would go into a nursing home, or a long-term care facility, not really knowing what they were getting into, to try to isolate individuals. They would often put themselves at risk if it was a large outbreak in a large facility with many, many people getting sick. And that was often a place like a jail or a meat processing plant, where there were a lot of people who they would need to go out and begin doing the testing. They were putting themselves at risk because they were donning PPE, but we now know that only goes so far, and they were putting themselves at risk for getting sick as well. And so, I always respected our nurses, but I really do consider them heroes, those individuals who were working ridiculous hours and were doing it selfishly when their own family members quite possibly were sick and trying to deal with things at home themselves. And of course, I'm sure that you have heard the stories about the nurses at the hospitals as well. And the other care providers who, just what they had to deal with, seeing individuals in ICUs not being able to come out of that ICU unit. So yeah, they saw a lot, they had to deal with a lot, and I'm sure it's something they'll never forget.
So you've had a long career with the State Health Department, and you talked a little bit about the Turning Point Council, which I had jotted a note down about that. How do you think your education and your experience helped you in this position to deal with the crisis?
I think my experience in particular, I had a very good working relationship prior to the pandemic and prior to retiring. I had a very good relationship with most all of the regional directors. And so I had built those relationships over time. I loved working with the county health departments. And I loved working with community partners. And I think that experience served me well in responding to the pandemic. I think I had a pretty high level of trust among the regional directors, and they felt like they could talk to me about anything. They could yell at me if they needed to, and they weren't really yelling at me. They were yelling at the situation, but I was that sounding board. In that period between March 15th and August 1st, I don't think I had ever heard more F-bombs in my life than during that period, but they had to release something.
Yeah.
And so I think, and I think because they felt comfortable doing that, I think and the reason they felt comfortable being able to do that is because of those relationships that I had built up over my practice career. And so that was important. And of course, my education was key too, in terms of just having that basic public health knowledge, understanding the importance of community engagement, and working with community partners. That was all very helpful. And I might mention that when I came to the academic world in August of 2020, those 6 months that I was at the state health department working the pandemic, even though it was extremely difficult, those 6 months have served me well as I now teach students and work with faculty. I use those experiences every semester now.
How has the curriculum changed?
The curriculum has changed. I teach one class called it's the Integrated Public Health Practice. And it is the capstone course that I teach for all Master of Public Health students. And I have changed the curriculum so that the second half of the class is all about emergency response. And I go over, and I still use COVID. I may change it up here in the next few semesters, but we use the pandemic response as an example of how to do an emergency response. And so I have them go through incident command system training. We go through each step of developing a risk communication plan. And then we do something that we call the last 3 weeks, something called a tabletop exercise, where we actually do a mock pandemic response and focus on about 6 different objectives during those 3 weeks. So it's changed significantly. Half of the class is now all about emergency response and how public health should respond and can respond effectively.
And these students lived through the pandemic too.
They did.
So
they did.
Does that come out in the class when you're going through this?
It does. It does. They've had their own experiences. Some of my students are physicians who are getting their Master of Public Health degree. Some are nurses, nurse practitioners. So they all have their own experience that they can relate to. But all of them, I think, find the class very useful, particularly if they are wanting to continue after completing their Master of Public Health degree in a public health practice career. I think it's information that they need to know.
Mm-hmm. So how has the pandemic affected employment in public health?
We still don't have enough workers. And I thought that we would have a lot more people coming to public health, interested in a public health career. But I think we're still struggling to hire sufficient numbers of individuals to work within the public health system. What the pandemic did do was help us to understand some of the gaps that we have in the current public health workforce. Those gaps still exist. It helped us to understand some of the training needs that we need for current public health workforce staff. And I'm actually currently working with the State Health Department on a public health workforce training initiative where my area here in the Hudson College of Public Health is going to train public health staff all across the state on basic public health 101 and then higher level public health concepts for mid-level managers and then more leadership development for executive level staff. But many of the staff currently in the workforce have had no public health training. So they need basic public health training. And even those individuals that are coming into the public health workforce typically still are not trained in public health. And so there's a need for ongoing training, for public health 101 training, and just getting people more interested in public health, I think, is going to be an ongoing challenge.
What are the toughest jobs to fill?
Toughest jobs to fill. I would say one of the toughest ones to fill would be the public health nursing positions. Public health isn't as competitive as other positions in the healthcare system. So you have to be passionate about public health and prevention and working with community members in order to seek out those positions. So those are challenging. And then some of our frontline staff, I think, are still challenging to hire. Those administrative assistants, those administrative clerks that check people into the county health department, I think are challenging to fill as well. So kind of those entry-level positions, as well as the public health nursing positions, I think are still challenging to fill.
Okay, I read about the Hudson College of Public Health, the multi-sector initiative to assess Oklahoma's preparedness for future pandemics and other public health threats. And the summary report, Achieving a Healthy Oklahoma, was released last year, and it's online.
Mm-hmm.
Took a look at it. So how is that going? Have some areas achieved a little more momentum than other areas? Can you address that at all?
That initiative is going well. We just had a meeting with our key steering committee a couple months ago. We still have a lot of work to do, but I think we're making some progress, particularly around some of the community partnerships. We've engaged other sectors such as business and education. I think many of the partners that we worked with through the Achieving a Healthy Oklahoma initiative didn't realize that they actually had a role to play in public health. And once we met with them and talked about what we were hoping to do in terms of the, taking a look at the pandemic response, looking at what went well and what did not go well, getting their recommendations for improvement, then they suddenly saw that, oh, gee, we do have a role, not just in a pandemic response, but for public health improvement overall. So I think working with the Achieving a Healthy Oklahoma initiative and the steering committee, we're now at a point where we are kind of moving past the pandemic. We have developed this relationship with the steering committee, and we're beginning to look at how we can work together, these different sectors, for improving Oklahoma's health overall. And so to me, that's exciting. It's kind of a moving forward. We finally see a path out of the pandemic and really using what we have learned through the pandemic, using those relationships that were either newly developed or re-engaged, and then moving forward with community health improvement overall for the state. So to me, that's exciting. I think I see a lot of promise in working with those leaders. And again, their business, education, foundations here in the state, healthcare providers, healthcare systems. So I think we all now have a common goal of working together to improve the state's health overall. So to me, that's exciting.
Okay, I'm going to backtrack just a little bit here. So in the fall of 2020, you had started your academic position here. And what was happening pandemic-wise with your new position that you were dealing with?
Well, for the College of Public Health, of course, we were in the middle of the pandemic still in August of 2020. And so we were doing many of our classes via Zoom. And so that was kind of a challenge to learn how to be effective at teaching via online systems such as Zoom. And so that's what we were dealing with. Of course, everybody was wearing a mask and, getting students engaged during that period was, I think, more challenging than it normally would have been. We're kind of past that point now where our classes are all in person. But we learned a lot. We learned a lot about how to be more effective with online courses. And so from that standpoint, I think in some ways it was helpful for us to learn how to do online courses and online programming for our students. Because that's kind of the direction that many universities are moving now, as you know, at OSU, I'm sure is doing the same thing. But I guess when we were all kind of thrust into that kind of rapidly, we were not quite ready for it. And we had, we made some mistakes along the way, probably may not have been as effective as we could have been, but we finally got our footing and I think pulled through that okay with our students.
Leading into the winter of 2020 into 2021, there was a lot of discussion then about a second wave of COVID aligned with the change in the weather. Mm-hmm. How was that changing things?
In the winter of 2020? Mm-hmm. Well, that was an interesting time because there was concern for another wave. And we did see some increased cases, I think, beginning in January. But also at the end of December was when the vaccine was rolling out. And so it was, while we were still concerned about additional waves coming with the pandemic, there was also some excitement that, hey, we have this vaccine now, maybe this will help decrease some of those waves. And so that was exciting to have that roll out and see that the public was getting vaccinated, and everybody here on campus. We were fortunate to have those vaccines available to us here on the Health Sciences Center campus, starting at the end of January or end of December, and then into the new year. So while there was concern about additional waves, there was also some thankfulness that the vaccine was finally rolling out.
Were you surprised with the people around the country, not just here, but the anti-vaccine movement? Yeah. During that time, yeah. Which was really picking up steam too.
Yeah. There was a lot of information going around, not all of it accurate. And certainly, I think some of that can be attributed to some of the information that was coming down, the inconsistent communication that was coming down starting at the federal level. Mm-hmm. People were confused. People were unsure what was accurate information and what was inaccurate information. And so I think that contributed to some of the mistrust that we're still experiencing with public health. And so, I think the only way to deal with it is to stick to the science the best that you can. Be consistent with your messaging the best that you can, even while there is other misinformation being promulgated. All we can do as public health professionals is stick with the science and be as accurate as we possibly can with our communication messages. So, but yeah, that continues to be an issue, and I think will probably continue to be an issue for quite a long time.
Was there a sense that things were going to get back to normal with the vaccine availability and rollout?
That was certainly the hope, and that was part of the excitement when the vaccine started coming out at the end of December in 2020. But then the pandemic didn't go away, did it?
No, we had the variants.
So I don't think we saw that coming. So I think the initial excitement kind of went into disappointment and concern, and honestly, I don't know that I could have lasted much longer than August of 2020, just because of the intense work. But the public health staff that I worked with were still working at the county health department, and then they were dealing with not only trying to get the vaccine rolled out, but then these new variants that were coming. People were getting sick again. I don't know how they kept going. Honestly, I just don't know how they kept going. Mm-hmm.
So it's hard to believe we're in 2023 now.
Yeah.
So does anything stand out to you about last year, about 2022 in the pandemic?
2022 seems like that. I think we were finally getting hopeful in 2022. Sure, there were some new variants, Omicron and some of the other variants that were coming out, but they didn't seem as severe. People were getting sick, but the number of deaths were decreasing. And so I think 2022, we began to get hopeful that we were finally getting through the pandemic and we could see light at the end of the tunnel. Between individuals who had been vaccinated or who had some level of immunity from an infection, certainly helped get us moving in that direction. And of course, recently with the declaration that the pandemic has been over, I think a lot of people were celebrating. And I noticed a few Facebook posts from some of my county health department colleagues with big smiles on their faces, marking it as a significant day when the official response ended at the federal level. I think it was May 11th. A lot of happy faces. And I think they were all looking forward to just doing good old regular public health and prevention again. And I have to tell you, working with the state health department for doing the training initiative that's going to be coming up over the next year, I'm really looking forward just to getting out, seeing all my colleagues, doing some basic public health training with them, and just getting re-engaged with them on something other than COVID. Looking forward to that.
Yeah.
So.
Well, and then we had the boosters too.
The boosters, right?
Yeah.
Yeah. And that was just kind of I just kind of considered that an ongoing part of the vaccination process. And I think that, that was helpful to help get the pandemic finally toward the end of the critical period.
Some people were talking about how the boosters would become like the flu shots that we get every year. Do you have any insight into that?
I don't know that I have a whole lot of insight. I think that certainly is a possibility where, that people may be, it might be considered a good thing to get a booster right around the same time you get your flu shot. I think that's the current CDC recommendation, although I have to be honest with you, I haven't kept up with it like I probably should have. But that's probably what's going to happen. The coronavirus is never going to go away. We do know that. It's going to be around in some form, hopefully not as deadly a form as the Alpha or Delta variants. But if we can keep it under control, and if it's similar to our regular flu season, then it's something I think is manageable.
Okay, I have a few questions about COVID on a personal effect for you. So, do you remember when you first began wearing the PPE and first time you put it on, and did you have problems getting access to it?
Well, yes, we did have problems getting access to it. But for the most, when we were in our own offices at the State Health Department, we generally did not wear PPE. For one thing, we didn't want to waste it. We wanted to make sure that we had adequate supplies to go out to the counties for our nurses and first responders. But when we were in large groups, when we were in large meetings, everybody donned a mask, a surgical mask. We tried, in particular, to not use the N95s or KN95 masks. Again, those were considered critical supplies for nurses and first responders. But yeah, we started wearing masks pretty early on when we would all meet at the State Health Department together face to face, particularly the situation room, the emergency response situation room. There'd be 30, 40 people in that room. And so everybody, of course, would be wearing a mask. And then when I finally left the health department and started teaching, of course, we all wore masks here in the building as well. Not in your own office, but if you were around anybody, it was a requirement to wear a mask.
Do you remember when you were able to start going to the store and things without one, how that felt?
It felt good. Yeah, it felt good. And I'm trying to remember when that first was. It probably not until sometime in 2021, maybe, or late 21, early 22, I think. But yeah, it did feel good to not wear a mask.
So, back in November and December of 2020, did COVID considerations change the way that you celebrated holidays or gatherings with family?
It did. Yes, it did. So just to give you a personal story, my father contracted COVID in January of 2021. He had attended a Christmas dinner, even though I warned him against doing that with probably 20 people. And he was not wearing a mask or anything. And he came down, he was 9 years old. He came down with COVID. And he passed away in January of 2021. So I was, because of, and it was we were heavy into a big outbreak at that time. And I did not even go to his funeral because my sisters, they're older. I have older sisters, they're in their 70s. They were concerned about me even coming to the funeral. So they just, my sisters and my nephew had a small memorial service, buried my dad next to my mom. And it was just my sisters and my nephew and the preacher. Of course, all were wearing a mask. So yeah, it impacted on me on a very personal level. and was not able to. And I just actually recently, last year, about a year later, finally went up and saw my dad's gravesite and everything. So.
Did you have any tense situations talking with friends or family members about the pandemic?
Tense? I don't know about tense. I think the conversations that we had, well, maybe tense with my dad because I could not convince him. I could not convince him to be safe. But I wouldn't really say tense. I think it was more conversations about being concerned and being careful and being smart. I wouldn't say tense necessarily.
Was he of the mind that he wouldn't get it?
I think so.
Yeah.
You know, he was kind of old school and thought he was as healthy as a 20-year-old and just didn't believe he could get it. And unfortunately, that wasn't the case. So.
Is there anything that you would change or do differently in any of the roles that you were working in during that time period?
Any of the roles? Maybe the only thing I can think of, I mean, I spent so much time just because things were changing so rapidly. I felt like I had to be at the State Health Department building every day, you know, nearly 12 hours a day. If I could change one thing, I would go out to the counties and, you know, put on my PPE and go to the nurses and go to the regional directors and just tell them how much I appreciated what they were doing. That would be the one. I don't think I said that enough. That would be the one thing I would change.
Is there anything positive that you have seen come out of this pandemic that we all went through?
Well, I think, yes, there are a couple things. Again, I think we, on a very basic level, I think we understand how much we depend on each other. We understand how we're connected to each other more than we probably ever have been. I think we understand the importance of those relationships and those partnerships more than we ever have understood before. And hopefully, once we get past the pandemic a few more years, people will understand better the importance of public health and how we responded, how we hope, I think, made a difference. Sometimes I think it's hard for people in the middle of it or shortly after the pandemic to really see that. But I think as we get further down the road, people will understand, you know, these public servants who put everything on the line to help others really did make a difference. And so I'm hoping and I'm thinking that will be a positive outcome.
What would you tell anyone who might be thinking about going into public health?
I would tell them my own story and tell them that if I had to do it all over again, I would not change a thing. I love public health. I love being able to make a difference in communities, and I love being able to help other people. I would tell them if they want to have a career where you, at the end of the day, you can look back and say almost every day, you know what, I think I made a difference today. Public health is what you should get into. You're not going to get rich, but you're going to make a difference in somebody's life every single day. And that's what I would tell them.
Imagine someone listening to this or reading the transcript 50 years down the road.
Yeah.
Knowing what you know now, what do you think that individuals, communities, or policymakers need to keep in mind for the future?
Don't make the same mistakes we did. Look, if somebody is looking at this 50 years down the road, look at what we did, look at the mistakes we did, and try to do a better job. I mean, we learned a lot, but we certainly did make mistakes, particularly around the communication pieces. Be prepared. Have PPE ready to go. Rotate the stock. Keep it up to date. Have testing supplies available. You never know when the next pandemic is going to come. So I hope that people in the future looking at this will not make some of the mistakes that we made. And then importantly, keep politics out of it. It's, for whatever reason, and I still don't completely understand it, COVID became a very political issue, became a red and a blue issue, and it shouldn't be. It should be about saving lives. And so if anybody looks at this in the future, focus on saving lives, focus on keeping the public safe, focus on getting out of whatever the pandemic is that they're currently in and getting past that. Keep politics out of it. I think that's the most important message.
Mm-hmm. And hopefully regaining trust in science.
Absolutely. Science isn't perfect. But what science does is once we understand that there was perhaps an error or a misunderstanding, then we make the correction, right? That's what science is all about. It's about looking at the problem, testing it, making a course correction if needed, and moving on. That's what we should try to do in public health. We're not going to always have the perfect response initially, but we will learn from that imperfect response and then do better next time. And that's what we need to continue to focus on.
Is there anything that I haven't asked that you would like to share?
I think I would like to say that the pandemic response was such a huge challenge for so many people. It was, for those who responded to it, it was challenging, it was difficult. They were trying to respond to the pandemic while, as I mentioned earlier, their own family members were getting sick and dying. But the thing that I want to leave with is just the heroism of those who were working the front lines, the public health nurses, those in our healthcare systems, who were simply trying to save lives and make a difference. I cannot emphasize enough how they are such big heroes and how they made a difference. That's what I would like to end with.
Okay. Thank you for the interview today. I appreciate it.
Of course, my pleasure.
Okay, we turned the camera off for a minute, but now we're back on. And so I'd like to share with you, Kelly Rader she's a regional health director, which you mentioned quite a bit in our interview. And when I interviewed her for this project, she said, and I quote, "He helped us as a point person in the central office and especially through the most difficult times early on with testing and with spikes of disease, hospitalizations, and lack of ICU beds. And she said, I quote again, that you were in the thick of things. Then she went on to say that you were a tremendous help and ear and a huge assistance for her professionally. So what would you like to add to that?
Well, I would just like to add that Kelly is probably one of the most dedicated public health professionals you'll ever meet. Her passion is endless, and she every day was trying to figure out what she could do to help end the pandemic or at least keep people safe. And she is really the one who was pushing hard to do something about the cases and the deaths in the long-term care facilities. So it was Kelly's idea to develop these rapid response teams. And she pushed hard to get this going and get this developed. And I had the privilege of working with her to develop a system that would create these rapid response teams. We worked with the long-term care service at the state health department to get them involved as well with their long-term care nurses who typically would do the inspections at long-term care facilities. But this was all Kelly's idea. And once we got these rapid response teams set up, I think they really did make a difference and reduced the number of deaths and cases in long-term care facilities. So I can't give her enough credit for what she did. She saved lives.
That's nice. And was it also helpful that Keith, with his GARD experience, how was that instrumental?
100%.
Keith Reed.
Keith Reed, absolutely. His military experience, he's a colonel now in the Air Force Reserves. But because of that experience, because of he was well respected within the military ranks, he was able to talk to the governor and to the general over the Oklahoma National Guard about deploying National Guard troops. And they saved us. They saved us in a number of ways. They helped us get samples, as I mentioned earlier in the interview, to the testing facilities. They were helping with testing sites, we call them pods, points of distribution. They would help us with testing all around the state. They would work with county health department staff and just direct traffic as we were trying to deal with the pandemic. They were an absolute critical piece of the response, even data entry, those kind of things that we just were running out of capacity to do. The National Guard stepped in and helped us. And so Keith's connection and his role as in the Air Force Reserves gained him the respect that was needed to make those requests. And those requests were granted by the governor and by the general in charge of deploying the troops, the National Guard troops.
From where I was sitting, it seemed like Oklahoma's response was better than some of the other states around us, for sure.
I think it was. I think we had good leadership in place. It wasn't perfect. Again, we made mistakes, especially at the beginning. There was a little bit of confusion at first between the emergency response situation room at the state health department and the MAC at the executive level with the governor's office. A little confusion about who was in charge and who was trying to give the orders. But ultimately, it was the governor's decision to make things happen. And a good example of that is the National Guard. So we learned to work with the executive office, the situation room, and the emergency response team at the state health department, developed eventually a good working relationship with the MAC which included not just health department, but other cabinet secretaries at the executive level. And we all worked together on the response, and we made it happen.
Remind me again what MAC stands for.
Multi-agency coordination.
Is that something that they still have?
I don't believe it's in place anymore. I think it was sunset once the main part of the response was finished.
So it was set up to deal with the
It's
pandemic?
set up specifically for the pandemic. Okay. And that's where Deputy Commissioner Reed at the time spent the majority of his time, and that's why I got so involved with the regional county health department directors.
Okay.
And it was an interesting system, and I just want to give Keith Reed a lot of credit as well. We had to make some tough decisions about some things. Earlier in the interview, I described the problem that we had with lab capacity and not having enough labs to test all the samples that we were collecting. That was earlier on in the pandemic. And so Keith told the governor, hey, we have to slow down some of the testing because we don't have the lab capacity. And so, testing people, taking samples, and then not testing them in an accurate, a timely manner is not doing anybody any good. And the governor said, well, just go ahead and test and then freeze the samples. And Keith pushed back and said, no, we're not going to do that. We wound up, telling the county health departments to halt their testing, even when the governor was telling us to do more testing. Mm-hmm. So Keith got called to the governor's office, and he got his butt chewed out. And I thought at that time that both Keith and I were going to be fired. But we weren't. Keith took a very science-based and brave position. And after several more meetings with the governor understood the reasoning behind our slowing down until we got the lab capacity in place. And so that's the definition of a leader, is to be able to tell your superior to tell him things that he doesn't necessarily want to hear, but to use science to make your point. And that's what Keith did. And as a result, Keith is now the commissioner of health. He was appointed by Governor Stitt because he gained that respect in that moment.
Mm-hmm. Yeah, that's good. I'm glad we turned everything back on so we could add these bits of information. Anything else that you can think of?
I'll probably think of things tomorrow.
Oh.
It might be too late by then. But no, I think we covered most of it pretty well.
Okay. All right. Well, thank you again.
All right.